It's my pleasure to introduce Dr. Priyanka Satish. Before I begin, I would like to note the fact that after 20 years in the South Asian Heart Center, all the individuals that are volunteers and members of our staff still look the same way as they looked 20 years ago. That is actually a testament of the benefit of our lifestyle program. Today, we actually have Dr. Satish with us. She is actually an expert in cardiometabolic disorders and in the screening for cardiovascular risk factors for coronary artery disease. And she is from Austin, Texas, and she is co-director of the fellowship program at the University of Texas Medical Center. She actually will talk to us about why we do what we do to get a better understanding on how to approach the many tests and technologies that are available to identify the individuals who are at risk and not at risk for cardiovascular disease. At the end, we will have a question and answer period, and so we're looking forward to your questions. Please welcome Dr. Satish. Go for it.
Thank you, Dr. Molina, and thank you, Mr. Mathur. It's really great to see such a large group of individuals interested in preventing heart disease. That is very heartening to see, and I think this is the right first step. And really, thank you to the South Asian Heart Foundation for really taking the initiative to make this data available to everybody and spread the word about this. So the really good work that you're doing and all the education that you're doing, I think will really make a difference. I am going to try and share my screen, and hopefully you guys can see it.
We can see your screen now.
Perfect. Okay, great. Okay, so today, we're talking about preventive testing for heart health. And why does this matter? And what are some useful tests that are recommended for screening for heart disease? Can you still see my screen okay?
Yes.
And it's moving?
Yep.
Okay, great. Okay. Before we get started, the big picture in all of this is we keep getting asked why are so many young individuals of South Asian ethnicity, but really seen everywhere. Why are so many young individuals developing heart disease? We hear of people dropping dead of heart disease really early. Why is all of this happening? Has something changed? Is this all new? Are there things we can do about it? So a lot of what we're going to talk today is going to be about that. Just some disclosures. Opinions are my own, don't reflect the views of my organization, and this is all educational. We'll start with a couple of words that get thrown around a lot if you're trying to read up something about what is heart disease. The words you'll typically see are atherosclerosis, which is a buildup of fats in the artery wall. So you have three big arteries that supply blood to the heart itself. And you see two over here, the other one's sort of in the back. And if I opened up one of these arteries and I showed you what it looked like, it would look kind of like a pipe. And this yellow stuff in the sort of in the side and the walls, that is called atherosclerosis. And the buildup is called plaque. The process is called atherosclerosis. So when doctors tell you you have plaque in the arteries of the heart or plaque, depending on how you pronounce it, that fatty deposit is really what they're talking about. So on the image to the left, you have a normal artery where you see the blood flow is just flowing no problem. And on this right image, you see the plaque deposition. Can you see my cursor also?
Yes,
Okay.
we can see your cursor.
Perfect, perfect. Okay. So now this plaque starts very slowly. So it starts as just tiny specks. And then as it keeps building up, it can start obstructing the flow to the artery. So think of it like if you have a pipe and you just keep getting scaly deposits in them, and at one point it can just grow in and completely obstruct the flow. So if that happens slowly, that gives you symptoms like chest pain, right? When you're exerting yourself, you start getting chest pain. Whereas if it happens suddenly, that when that happens, that completely cuts off blood flow to a particular part of the heart, and we call that a heart attack. So when people say this person had a heart attack, what they mean is they had a sudden cut of their blood flow to a particular region in a particular artery. Now, there are a couple of things that you should know. Plaque buildup is a very silent process, so you can have absolutely no symptoms when all of this is happening. And that's part of the reason why it presents very suddenly one day, and still the day before, you could be great, you would be exercising, you'd have no symptoms. You may even have passed a stress test. That doesn't rule out that do you have plaque or not. And so again, symptoms may develop gradually if it sort of builds slowly, but it can very easily develop and come on very quickly and sort of out of nowhere. So that brings me to the question, what is happening to young people and young hearts? And if you ask 10 different people, they'll tell you 10 different things. So some people say it's genetics, others will say, it's a lifestyle, our stress plays a role. And then a lot of people say it's fate and, we are born with this risk and there's nothing we can do about it. And some parts of this are true for South Asians where there are data that South Asians are, at 2x the increased risk for heart disease compared to, say, Caucasians. And this has been shown across multiple data sets in the US and Europe. So there is definitely an increased risk. But the fact that I don't agree with is that there's nothing you can do about it. And this is the most important part because if you catch heart disease early, you can beat it. And if you catch risk factors early, you can even prevent it. So that is going to be the meat of our talk today. And now, when I talk about cardiovascular risk, a lot of people will ask me, what do you mean by risk? And so, when we're talking about your risk for heart disease, essentially what we're trying to do is we're trying to look at large data sets full of, hundreds of thousands of people. And we're looking to see what factors among that people have can help sort them out into either somebody who's going to get heart attack or somebody who's not going to get a heart attack. And if we look at large enough groups of people, we can actually find these things. Oh, okay, if you have X, Y, and Z factors, that puts you at a higher risk. Versus if you don't, you may be at a lower risk. So that's what we mean when we talk about cardiovascular risk. We talked about risk factors, and this is a lot of the stuff you guys would already have heard about. So there are certain things we cannot help. So age, sex, the South Asian ethnicity, uh, family history of heart disease. These are things that we don't really have too much control over. I'll come to lipoprotein A later. But there are this whole host of things that we do have control over. So things like, your cholesterol level, things like blood pressure, diabetes if you have that, and then everything that comes as an underlying factor for all these other risk factors. So your diet, physical inactivity, visceral obesity, tobacco use, right? These are all what we call modifiable risk factors because we can make a difference in our risk just by addressing these risk factors. I also want to bring up the topic of cardiovascular risk enhancers. So what does that mean? Cardiovascular risk enhancers are features in your history that can clue us in as doctors to tell you that, your risk may be a little bit higher than we had previously thought it was. So remember I said, if I go back to this image, I said, I'm going to take a look at you and try and put you into one of these two buckets. The risk factors help us do that. So if you have hypertension, diabetes, yes, that puts you at a higher risk. But if you say you don't have those, then we can again look at cardiovascular risk enhancers, and then that might help us, classify you into either higher risk than before. So So, what are cardiovascular risk enhancers? So, the first thing that is important for women to know is that complications during pregnancy can sort of be a window into your future cardiovascular health. So that's like things like preeclampsia, things like gestational diabetes, having a premature birth for some reasons, multiple miscarriages, early age at menarche, early age at first periods. Those can kind of clue you in. There we call them like sex-specific risk factors that can clue you into, hey, maybe there's something going on in this person's vasculature, in their biology, that if we don't address it, it can raise your future cardiovascular risk. Now, I don't want us to look at this and say, hey, oh, I have this, therefore I'm doomed to get heart disease. That's not true. So it's just a warning sign, and it gives you a large window because imagine most women are going through pregnancies, 20s, 30s, right, maybe 40s, right? That still gives you a long window to be able to address as many modifiable risk factors as possible. So think of it as kind of a warning bell that there may be something going on, and you want to talk about how your care team can manage that risk for you. And a lot of the lifestyle things that are really important and get emphasized are very important to help change that trajectory. The only other thing I'll say about cardiometabolic disease in pregnancy is that it is multi-generational. What do I mean by that? If a pregnant woman has, say, a cardiometabolic disorder, like say gestational diabetes, for example, the infant has a higher risk for developing similar cardiometabolic disorders. It's not a big effect, but there is an effect where staying healthy earlier and earlier on can be really beneficial, not just for you, but really for your kids as well. So that's just something to be aware of, that these things can clue us into future cardiovascular risk. And if there is a reason why pregnancy gets called the stress test in itself, because there are so many changes going on in the body, if there are problems, it'll typically show up. Now, other things, we'll skip over chronic kidney disease for a second and talk about fatty liver. Fatty liver is one of those canary in the coal mine kind of risk factors. We think that, oh, it's just a little fat in the liver, and people get told, oh, it's so common. Everybody I know has it. It's not a big deal. But honestly, it is a big deal. Um, People with fatty liver disease can progress to future liver disease itself. So you could get cirrhosis, hepatitis, cirrhosis. But really, it also increases your risk for heart disease because the same things that is going on in the body that's causing fatty liver can later cause heart disease also. So if you have fatty liver, take it seriously. Lifestyle becomes extremely important in this condition, and you want to try and modify that trajectory to prevent future liver problems, but really also prevent future heart disease. The other good thing about fatty liver is lifestyle is super effective in melting away fatty liver. So in many people, even if you have abnormal liver enzymes and fat deposits, a healthy lifestyle, if you have excess weight going on and losing some of that weight, can be very, very helpful. Now, this is, lifestyle is not the only cause of fatty liver, so you still should get evaluated. But in many, many people with what we call non-alcoholic fatty liver disease or non-alcoholic steatohepatosis, this approach to intensive lifestyle modification can be super, super helpful. A couple other things raise your risk for heart disease. So having chronic kidney disease can raise your risk for heart disease. In fact, in people with advanced kidney disease, heart disease is the most common cause of death, not dialysis-related complication. And then inflammatory disorders. So having a systemic inflamed state can increase atherosclerosis, can increase your risk for heart disease. So that's rheumatoid arthritis, inflammatory bowel disease, psoriatic arthritis. If you have a history of those, it is probably a good idea to talk about, do you need additional screening for heart disease? So I want to talk about what screening tests do we recommend? And really, I'm going to break this down into early, so like young adults, and then like sort of 30 plus middle-aged adults. Everybody should get a cholesterol check. In fact, the earlier you get it, the better, because there are rare genetic conditions that can be detected in childhood, and that can be treated. So everybody should get a cholesterol check. Everybody should get a blood pressure check. And then, in your 20s, probably a good idea to get your sugars, your hemoglobin A1C check. In people with metabolic syndrome, fatty liver screening can be considered. Now, what is metabolic syndrome? I didn't define this. Metabolic syndrome is a syndrome of insulin resistance. It's what we see very commonly in South Asians, where you have a little bit of belly fat. You're not truly, you don't have a truly high BMI, but just a little bit of body fat, especially in the belly region. And then you start seeing associations with like fatty liver, hypertension, polycystic ovarian syndrome. So a constellation of these findings, if you have abnormal triglycerides, for example, that's good. That gets called metabolic syndrome. Um, and in people with metabolic syndrome, fatty liver screening can and should be considered. Now, the second thing I'm going to say is if people are over 30 years, especially in the South Asian population, heart disease screening can be considered. Now, this is a little bit controversial. This cutoff is a little bit controversial. Most guidelines recommend 40 years, 40, 45 years. But South Asians develop heart disease early. So we have a higher burden of premature coronary artery disease. So if you have a lot of risk factors, you have a significant family history with people in your family having heart disease at a younger age, screening for heart disease can be considered, earlier than recommended cutoffs. And the last thing to remember is that just because you have no symptoms, that does not mean that you don't have heart disease. So I'm going to say this again. You can run every day on a treadmill, have absolutely no problems. You can be hiking. You could have passed a stress test with flying colors. None of that guarantees that you don't have plaque in the arteries of your heart. The only real way to look at do you have arteries and do you have plaque in your arteries is to go and take a look at the arteries, and we'll talk about that. So I want to spend a couple minutes talking about our screening tests. So the routine lipid panel is what your doctor will order, also called a cholesterol check. And you get multiple results on your lipid panel. So the first thing will say total cholesterol. That's always on top of the panel. But I want you to go down below and pay attention to the LDL level. And that because that matters more than the total cholesterol. When we have metabolic syndrome, we see a very classic pattern of high LDLs, high triglyceride level, and a low HDL. So these can all clue you in that there is some insulin resistance, some metabolic syndromes, a combination of that going on. It's not the only reason to have high LDL levels, but it is a very common reason. And the good thing about this is that it is very lifestyle treatable. So having metabolic syndrome is very, very responsive to lifestyle. Not all LDL levels, however, will respond to lifestyle. It's still worth trying though. The second test that if you walk away from this talk and you want to learn something, there's going to be a couple of things. The second thing I would say is important is to remember to ask for something called an ApoB. And ApoB is short for apolipoprotein B. We'll go over what that is, but if you don't want to get into nitty-gritties, just ask your doctor, can I get an ApoB test? And it's a blood test. It's not too expensive, and it can be ordered on top of your routine lipid panel. So for those that want to take a deep dive in, this is the difference between LDL and LDL-C, the metric on your lipid panel, and an ApoB. So a lipoprotein is a particle that contains protein, cholesterol, and fat. So it's each of these big like circles. LDL stands for low density lipoprotein. That's just a property of it. And the LDL-C that you're seeing on your routine lipid panel, I said you get your total cholesterol, HDL, LDL. That is the mass of cholesterol in the LDL particles. So that's the blue inside these. ApoB is a measure of the number of particles. So if I have more particles, my ApoB is going to be higher, versus if I have less particles, my ApoB is going to be lower. And it turns out that the number of particles matters more than the size of the particles, and it matters more than the amount of cholesterol in them. So the reason ApoB is such a useful additional test is because you can have a good looking LDL number, but you still have a high particle count. So if you have a bunch of small particles, the total amount of blue in them is still going to be small, but then your ApoB will tell you that you have a large number of particles. And then your risk is high, even though the lipid panel looks okay. So this gets missed a lot, and if we don't look for it, we're not going to find it. It's especially important in people with metabolic syndrome. And in the South Asian population, it has been shown that you can have sort of discordantly high ApoB levels. So the next time you go ask for the ApoB blood test, you don't want to get a ratio. You don't care about a ApoB to ApoA1 ratio. You don't need to do all that. Just get an ApoB level. So that's important with the cholesterol panel, but really at least everybody should have this panel where you get your routine lipid panel and at least look at your LDL level. Okay, I told you we'll talk about lipoprotein A next. Lipoprotein A is familially inherited, so it's genetically mediated, which means, if one person in the family has it, everybody needs to get screened for it. A lipoprotein A is in structure, it's kind of similar to an LDL particle, but think of it as the naughty cousin, right? It causes per particle count, it actually causes more havoc compared to an LDL particle. So if you have an elevated lipoprotein A, that puts you at increased risk for premature heart disease and really also aortic valve disease for some people. And one-time testing is now recommended for everybody. There are different cutoffs, and at least 50 is what gets called as elevated in milligram per deciliter, 75 if you're using nanomoles per liter. And not too many treatments for this as of today, but there are studies being going on that may tell us if treating this actually helps people. So this is just something that could be a unique risk factor. It is more commonly seen in South Asians compared to Caucasians, but really also in multiple other racial and ethnic groups. The next thing I'm going to move on from cholesterol, because we talked all of this time, we talked about cholesterol and how to check that and what to do. The next thing I'm going to move on to is blood pressure. Why is this important? Because globally, if you look at just the data from the world, high blood pressure is the number one risk factor for heart disease. Like it's high blood pressure, then it's diet, and then like below that is cholesterol. So if you haven't done so already, do get your blood pressure checked. And you can do this at home, in your doctor's office, the pharmacy, but don't ignore blood pressures. And the reason I'm bringing up this particular slide is because people will often tell me, hey, my blood pressure is just like 130 over 80. It's not so bad. It looks fine. It's not flagging as red on the monitor. And so I'm not worried about it. For young people, having a blood pressure of like greater than 130 or 80, that's stage one hypertension, is still a problem. It's still associated with higher risk of heart attacks because think of the duration for which your arteries of the heart, the brain, the kidneys are all getting exposed to that kind of pressure. So really, the goal blood pressure for most people should be less than 120 over 80. And that is where the data shows that you can minimize your risk for heart disease, but really this data exists for stroke as well. And especially if you have other risk factors, so if you have diabetes, for example, chronic kidney disease, you really need to get your blood pressure to less than 120 over 80 to prevent progression. And this is how treatment thresholds are now defined by the latest guidelines, where if you are greater than 130 or 80 and you're at low risk, meaning you don't have any of these risk factors like diabetes, like I told you. Lifestyle is, we do a trial of lifestyle because that is very effective. So all the lifestyle programs, the lifestyle changes that Mr. Mathur was talking about can be super, super effective for reducing blood pressure. It's just that you have to maintain it and sustain it. If that works, great, then you found a durable solution for it. That's great. If that doesn't work, then medication is still recommended. And the reason we do that is because we don't want to fall into this trap of oh, I'm going to improve my lifestyle. I'm going to continue to improve my lifestyle, and my blood pressure is elevated, elevated. And before you know it, it's 5 years. You haven't treated your blood pressure. It's slowly creeping up, right? We don't want to fall into that inertia. Of course, I have plenty of patients who have completely reversed their hypertension with lifestyle alone. And if that works for you, that's great. But if it doesn't, don't expose your arteries to that kind of pressure. Get it treated. Um, when we talk about other blood pressures, if you're over 140/90, typically it's a combination of lifestyle and medication that gets started together. Again, for the same reason that I talked to you about. But that doesn't mean that lifestyle is not important. Lifestyle is still the foundation for treatment of metabolic syndrome, for treatment of hypertension, diabetes. It can play a good role in reducing cholesterol levels. So it is still the foundation of all preventive therapy. The only reason I'm not going into that today is because that's not the focus of my topic today. But don't get me wrong, it is extremely important. So we talked about our metabolic syndrome a little bit, and we're going to talk about visceral adiposity today and why is that important. This was a seminal paper that was published in The Lancet many years ago now, where two doctors basically got DEXA scans looking at their body fat percent, and they compared it. So both doctors, this is a Caucasian doctor and this is an Indian doctor, both doctors had the same BMI of 22.3, but the Caucasian doctor had a body fat percent of 9%, but at the exact same BMI, the Indian doctor had a 21% body fat. And if you look at where the fat gets deposited, oftentimes it's here. It's in the abdominal region, it's in the belly, right? The little belly fat that we all find it so hard to get rid of. And it turns out that having that belly fat and the fact that we have that phenotype as South Asians, that's a problem. That predisposes you to insulin resistance and all of the other stuff that I talked about, the fat in the liver, like it predisposes you to heart disease. So if we want to get a true estimate of someone's metabolic risk and what their metabolic parameters are, either you got a DEXA scan and like quantify your body fat and quantify where exactly it is, or a fairly simple way to do it is just to check your waist circumference and to just note that there are different cutoffs in South Asians versus other ethnic groups. So if you have an elevated waist circumference, even if your BMI is normal, and like a BMI of 22 is great. So even if you have a normal BMI, you can have metabolic syndrome. You still need to get checked for it. And screening becomes very important in such people. A common term that gets used to describe this phenotype is called sarcopenic obesity. And that just means very low muscle mass versus a high fat, relative fat percent because our muscle mass is so low. So that's a term that commonly gets used to describe this. Multiple guidelines recognize this phenomenon that happens in South Asians, and we have different cutoffs, different BMI cutoffs for what is considered normal in South Asians versus other ethnic groups versus Caucasians, for example. And really, this is recognized by a lot of guidelines where all of them say if you have a BMI greater than 23, get screened for diabetes. And really, I'll expand this to say everybody should get an A1C screening. It's fairly easy to do. The other test you can do is of fasting and postprandial glucose, and there are nuances of when one is used versus another, but for most people, A1C is a pretty good test. Okay, now I want to move on to screening for heart disease itself. All this time we were talking about risk factors. So all the things that I told you that may help put you into one bucket or another. That is a good way to estimate on a population level who is going to get heart disease or not. But the problem with using just the risk factors is that even though we have all these risk models, we have risk calculators, we have all these tools that we can use, they're at best a guess, right? We don't know for sure exactly who is going to get heart disease or who is not going to get heart disease. So the real best way to check if what your individual heart disease risk is is to just take a look at the arteries of the heart. And remember, I told you you could be running a marathon, you could pass a stress test with flying colors, and you'd only know if you took a look. This is how you take a look. You get a CT scan. It's called a coronary artery calcium score. And you get a CT scan that basically looks for plaque. It takes 5 minutes. There's no contrast involved. And it gives you a picture. So this is a sample picture of a coronary calcium score. This is an axial section of the heart, and this is the heart itself. I know it doesn't look like the heart, that's because it's a slightly higher cross section. And what I'm looking at here is one of those arteries that I pointed to you at in the first image. So this line that I'm seeing is an artery. And all the white that I'm seeing on it, that's calcium. And that tells me that there is plaque in the arteries of the heart. So this person has a fair amount of plaque in their arteries. And this is important because there's a lot of data that shows doesn't matter what your risk factors are. If you have plaque, even if your risk factors are well controlled, that puts you at a higher risk bracket. So in terms of how we classify you into low risk, having a lot of plaque puts you at a higher risk. So this is a very important test. And we recommend it for a lot of people. After we look at your risk factors and sort of assess your individual risk, we recommend this for a lot of people. Okay. So we'll move on to who should get a CAC score, and this is honestly by no means a comprehensive list. This is just some framework for you guys in case it helps you have discussions with your doctors. So the first thing I'll say is calcium scores are recommended in people without symptoms. So if you have symptoms, you have chest pain, you have shortness of breath when you're exerting yourself, this is not the test for you. So pick a better test. There are different tests that you can do if you have symptoms. So this is for asymptomatic people who are at borderline risk, and we're trying to decide if you need preventive medicines. Maybe your LDL is a little bit high, and we think you might benefit from the medicine, but really we're not 100% sure because it's not high enough. That can be a good test. So if you have no plaque, then we de-risk you. You go lower on the risk. Whereas if you have plaque, you go higher on the risk. And if you have a lot of risk enhancers that we talked about, or if you have family history, those are all things that can clue us into maybe we should get a calcium score to assess your risk. People who have known heart disease, so if you have a stent, heart attack, bypass, you've had any kind of procedures done to your heart arteries, do not do this test. This test is not for you. You have already been diagnosed with heart disease. This test is just to diagnose heart disease. Or if the test will not change management. So we've already treated you, we've put you on max dose, we've medicines if needed, or your lifestyle's super optimal, and doesn't matter what we find on the test, then again, don't get the test. This data is hot off the press, so I'm sharing it with you guys here. All this time, up until 2025, when we got a calcium score on a South Asian individual, we compared it to a data set that had very few South Asian individuals. So the data set that we used to compare these calcium scores was called the MESA database. And now we have our data in South Asians, so we can find out exactly where you are based on your calcium score in comparison to other South Asian individuals of the same age and sex. So for example, if we take this person, and this is a man, so you have a South Asian man who's 39 years old, right? And he has a score, let's say, has a score of 20, right? That would put you in this green line, which then we can look at the curves and say, okay, you're in the 95th percentile for age. So what does that mean? That means almost 94% of people will have a lower score than this person. And I'm using this particular number to highlight something. In young people, well, they'll often get a scan and they'll get told, you have a very small amount of calcium, like your score is only 5, don't worry about it. It's almost 0, don't worry about it. Do worry about it. Don't don't be reassured by the fact that the number is low. The reason being, most 39-year-olds should not have calcium at all. So if you have calcification as a 39-year-old, automatically your trajectory is higher than the person at the lowest risk, right? So the teaching point, if you will, in this is that don't ignore a very low calcium score, especially if you're younger. As we grow older, having a little calcium becomes more okay, but in young people especially, do not be reassured just because the score is low. And the Lipid Association of India came up with a guidance statement on what do you do based on different calcium scores. So if your score is 0, that's great. It means you have no calcified plaque. If you have a score of 1 to 99, we look at your percentile for age, and then we target your LDL levels. And if you have a score, okay. And if you have a score of 100 to 200, again, you're in the high risk. And then the Lipid Association of India actually goes one step higher and says, if you have a score greater than 300, that we put it, get you classified into the extreme risk. This is only there in the Lipid Association of India guidelines. It's not there in other guidelines. But they're basically trying to get at, if you have a lot of plaque, you need a lot of prevention, and some of that is going to be medication. Now, again, that does not mean that lifestyle doesn't matter, but many times lifestyle alone is insufficient in some of these people. So this is how targets of LDL and ApoB work. And this again is from the Lipid Association of India statement. So if you're low or moderate risk, remember the calcium 0 group, you want to keep your LDL less than 100 at least and ApoB less than 90 at least. And this is the floor. Like you want to at least be here. If you want to go lower, that's better, but you want to at least be here. Now, if you're high risk, we say get your LDL at least less than 70 and ApoB for simplicity also less than 70. But if you're in the very high risk or extreme risk, depends on who you ask, but typically we'll say try and get your LDL to 50 or at least 30. And why do we do that? Because, it doesn't matter what started your atherosclerosis process. It doesn't matter what started the plaque deposition. We know that having a high LDL helps propagate the plaque, helps make it worse. So you want to try and take out as many of those LDL particles as possible from the circulation so that you minimize the risk of plaque progression and you minimize the risk of heart attacks, because really that's what you're trying to prevent. Okay, the last couple of slides I want to talk about just what a calcium score is and just a little more about that. So common things I'll often hear is people, will say, oh, I had a positive calcium score and they told me to get a stent. That's not always true. Most asymptomatic people typically don't need a stent. So just because you have a positive calcium score doesn't always mean you need an angiogram, doesn't always mean you need a stent. So that's just something that gets propagated a lot. But in my practice, a majority of patients who have a positive calcium score get aggressive prevention and they get medicines, they get lifestyle, but not always a stent. Second thing I hear a lot of times is, oh no, my calcium score is positive. This just means this is bad news. I can't do anything about this. I'm doomed for life. Again, not at all true, right? The reason we did this test is because we can catch it before it causes you any problems. And assuming you are asymptomatic, and that's why we did the test, it is not causing you any problems. So we have the time to make those lifestyle changes, to make those risk factor modification, to make a difference to your heart attack risk. And something I tell my patients is, yes, you have a positive calcium score, but my goal is to make it just stay as a picture on a CAT scan, right? We have so many things we can do to prevent this or seriously reduce the risk of this ever causing you any problems for a long, long time. So lifestyle and preventive medications can significantly reduce that risk. Okay. The third thing is, I think, equally important. So the third thing I hear all the time is a calcium score of 0 is great, right? Like I'm immortal. Well, that's not entirely true. The calcium score only looks for calcified plaque. You can have soft fatty plaque that gets missed by the test. And, about 10 to 15% of people with a calcium score of 0, if we do a full CT angiogram, we'll see plaque in them. It's still a good prognostic sign to have a calcium score of 0, but it doesn't mean you have no plaque whatsoever. It doesn't mean that, you can go eat that cheeseburger and go enjoy life with that pizza. No, you still have to take care of your risk factors. You still have to keep your metabolic syndrome under control. You still have to do all of those things. It's basically a test that allows us to titrate medications if needed in terms of how aggressive we want to be with your preventive medications. So a healthy lifestyle matters even if your calcium score is 0. And the other thing we'll tell people with a calcium score of 0 is that the warranty is good, but you still want to repeat it if you have risk factors. So every 3 to 5 years, we sort of recommend repeating the calcium score if it will change your management and if you have high risk. So the last, I think, one or two things that I wanted to bring up is that this test called a CT angiogram, and it gets called a lot of other things. It's called CTA commonly, and it can be used as a screening test also. The difference between a calcium score and a CT angiogram is the contrast that we give you. So they're both CT scans, so you need to go under the CT scanner for both of them. The calcium score is a 5-minute test. We don't put an IV cannula in your arm. We don't give you any IV contrast. Whereas if you're doing a CT angiogram, we give you contrast, we'll give you other medications to slow your heart rate. So it's a little bit more involved process. Now, the other difference is that a calcium score in the US does not require a physician's order most of the time. So you can walk into any center that does them, and typically they can do it for you. And it costs, anywhere between $70 to $150 depending on your site. Whereas a CT angiogram typically requires a physician's order, and then it's more involved. So there's contrast, you have to get screened. It's not for everybody. And the other thing is it's expensive. So it's, you have to go through insurance. So it's a whole thing. Well, why is there a conversation of CT angiogram? Um, that is because of all the limitations of calcium scores that I just talked about. I told you it doesn't catch soft plaque. So I want to show you some examples of what soft plaque looks like. This white tube that you guys are seeing right here, that's your artery. So I've given it contrast, so it's lighting up the artery. And this is a calcium, like a speck of calcium. So if I did a calcium score, I would see this part. What I would not see, and this is a little bit hard, is this thing that's eating into the artery. Hopefully you guys can see this semicircular sort of dark thing right here. That is soft plaque. So that's all fatty stuff. In the first picture, all the yellow things that I showed you, that basically comes on a CT angiogram as just soft, dark plaque. And you can have things like high risk plaque is something that we look at on a CT angiogram. And then the other word for soft plaque is non-calcified plaque. It just means there's no calcium in it. And all this, and this is another artery again. So this is the artery tube. All this black stuff inside the white is all soft plaque. And that's important to know if you have a lot of it. So it has been studied. We don't have a lot of studies, and our group is actually looking at some of this data. So we'll know more, and we'll be publishing some of this soon. But it appears that in some groups of South Asian individuals, you can have more of this soft plaque. And then if all you have is soft plaque and not calcified plaque, you're not going to catch that by a coronary artery calcium score. So you could have a calcium score of 0, and we're reassured. We think this is great. And you can still have soft plaque, and that gets missed. It's not a very common scenario for that to happen, but in some people, it can happen. The other thing that South Asians can have is more severe blockages. So remember, I said the plaque keeps growing inside the artery, and it can really narrow the artery and kind of pinch it, and that's called obstructive disease, and that's what commonly gets called, oh, I have a 90% blockage. That just means 90% of my artery got narrowed because of all the plaque in it. And then we also have higher volumes of like fat around the heart, and it turns out that's not great for you. So CT angiogram can give you a little extra information compared to a calcium score. As of today, guidelines for the most part only recommend CT angiograms if you have symptoms. So it is not yet recommended for asymptomatic individuals. That might change in the future. But as of today, it's for most individuals, a calcium score is sufficient. And that's something you can also discuss with your doctor if a CT angiogram is something that's worth it for you or not. There are a couple of downsides to CT scans. The biggest thing, in my opinion, is just that it's a lot more radiation exposure compared to a calcium score. And with radiation exposure, you start worrying about cancer, especially if you're getting multiple of these scans. The cost is higher, like we talked about. And then there are concerns that, we can raise your anxiety level if I show you an image like this of your artery where it looks super narrowed over here. Now you suddenly start worrying about every little chest pain that you have, right? So there are concerns that it might drive more stents, it might drive more anxiety. So it's not a slam dunk. Everybody should get it. I think many people should get a calcium score for their screening if they're at intermediate risk, but not a CTA for everybody, at least just yet. Okay. So the final couple of slides I'll say is what can you do as a community to improve awareness of all these things? The first step, of course, is you're here, which is great. You're spending you're spending like a couple hours of your evening with us. So I'm very grateful for that. But if you haven't watched this documentary, it's a really great documentary done by two physicians who basically took it upon themselves as a philanthropic project to educate people about this risk in South Asians. A lot of doctors even don't know this. And so this is a really great documentary. It's called The Brown Heart. If you just Google it, you can like say the Brown Heart documentary. It'll show up. It's free on YouTube. I also added a link to it here. And if you want a little bit more of a scientific presentation, this is a Grand Rounds conference that I did a couple years ago. That just goes into the nitty-gritties, the actual data on like what is the risk and what can you do about it. There are also programs that are South Asian specific. Obviously, you guys know our hosts for today really specialize in this and they do an incredible job. But there are others that that have people who are aware of this risk and sort of are at the cutting edge of this space. I just left a list over here. We are based in Austin, Texas, but there's really places everywhere. There are also studies that if you're interested in, it would be a good idea to get enrolled in because we don't have a lot of data in South Asian individuals. So we extrapolate a lot of things. Like I said, until last year, we did not even have calcium score data on South Asians. So we just got that. So if you want to contribute to the community, join one of these studies. Masala is based out of UCSF, and they have a San Francisco cohort. And Our Health is a genetic study looking at what are our genetic risk factors that might trigger this kind of visceral obesity phenotype. And then what can you do today? So make a move goal, make small diet changes. I have people asking me all the time, about small things. Should I use this versus that? Should I use this oil? Should I eat in this order, that order? My big thing that I tell everybody is, are you moving every day and are you eating just the bare minimum healthy lifestyle? So more greens than grains, your fruits and vegetables, and many, many people are actually not getting enough fruits and vegetables and fiber in their diet. They're not eliminating the junk food. There are a lot of fruit juice. I see people like drinking a lot of fruit juice, sodas. Those are all easy things that if you can swap out, you'll make a significant improvement in your health. And the second thing I'll say is if you're not used to looking at food labels, this is a great time to start. And I'm sure if you're working with the South Asian Foundation, you're going to get taught this. But you really want to optimize your fiber. You want to optimize your protein. Especially remember, I told you we have low muscle mass as South Asians. So you want to optimize your protein intake in conjunction with exercise, not just by itself. You want to limit your added sugar. So looking at the label is super important. And then you want to limit your saturated fat because saturated fat, raising your saturated fat intake can raise your LDL levels. So these are things that I'd recommend, I teach my patients to do and look at. And, a lot of programs do this, and you can find all of this online as well. So three big things you can do today. If you don't have a blood pressure cuff, buy one. It's extremely useful. You can buy it off of like Walmart for some $30 to $50. Remember to get a validated blood pressure cuff. That's important. If you haven't got your blood work done recently, don't assume that everything is okay just because you feel great and you have no symptoms. Definitely get a check so you can find out. And then finally, this is a plug for a calcium score, but really screening for risk factors, screening for heart disease. Make that proactive move today. Don't assume you don't have a problem just because there are no symptoms. Okay. With that, I'm going to conclude, and maybe we can take some questions.
Thank you, Dr. Satish, for a wonderful talk. We've got a lot of questions out here, so we can begin. So one of the first ones is for patients who already have cardiovascular disease and pre-existing plaque deposits, are there any factors that are more likely to trigger a heart attack?
That is a good question. So all of the risk factors we talked about, the blood pressure, high LDL cholesterol, diabetes, so insulin resistance, these things can all increase the risk of plaque rupture. So even though we kind of talked about it as a static process, like you deposit plaque and it stays there, actually that's not how the arterial wall works. It's a very dynamic process. So you continuously have breakdown of plaque, buildup of plaque, breakdown of plaque, buildup of plaque, and that cycle keeps happening. The things you can do to address that is just to take away all the things that help the buildup so that the takedown process wins, and the body is continuously trying to stabilize the plaque. And in fact, the calcification that we talked about, that we see on a coronary calcium score, tends to be a stabilization byproduct in some ways.
Then we have a few questions on calcium CT score. One of the questions which I wanted to ask was that at the center, we recommend calcium score at the age of 40. But you were telling us that you should go lower, for younger patients. So
the Lipid Association of India recommends starting a little bit younger, but it's really useful mostly in people who are at risk. So if you have a big family history of premature heart disease, like you've had somebody in their 40s who had a heart attack, for example, probably not a bad idea to start early. It may not be for every single person, but in people with high risk, fairly low, risk test to do. The biggest thing you should remember, though, that in your 30s is you're going to almost certainly have a calcium score of 0, and that does not mean you don't have a problem, right? The problem is if you have a calcium score that's not 0, anything other than 0, that's high. So it's useful in the sense that it'll guide preventive therapies if it's positive. But if it's 0, then maybe you're never going to develop plaque. But really, it could also just be that it's very early and we haven't caught it yet. And there are some people who are especially younger where we will consider a CT angiogram instead, because you can look at the soft plaque, and soft plaque is in sort of the earlier stages of plaque.
So what about the radiation exposure at a
It's definitely something we take into consideration, and that's why I say it's not for everybody. But the cancer risk with radiation exposure from one CT scan is really not that much. Even with a CT angiogram, is really not that much. So, we'll still have a discussion about it. But there are definitely some people, and I've seen patients where if you have a really bad family history and we're getting calcium score 0, but we still think you're at risk, we might do a CT angiogram as a screening method, at least once.
Thank you. There were questions about how often should one do the calcium CT scan? And the other one related was also, once you have a plaque, can it be reversed?
Yeah, it's a great question. So we'll start with the first one. A calcium score of 0, we typically recommend repeating 3 to 5 years in people who are at risk. And there's an age cutoff to this, so like after 70s, we don't do too much of it. But 3 to 5
Leo.
typically what we say, because
Eh,
it takes that much time to
déjame ver.
calcify existing plaque.
There's a
Plaque
question.
reversal, right? Okay.
Yeah, can
Plaque
you
reversal
repeat?
is an interesting question. Um, it has been demonstrated, it has been described. So there have been CTA studies where you get a CT one year and then you do a bunch of things and then you repeat CT next year and you look at has the plaque gone away? And it has been demonstrated. The things that help plaque regression is what we call it, or reversal, is really lowering your LDL levels. So if you get your LDL below 30, there has been evidence of plaque regression, especially if you start early. The other things, plant-based diet, so all the whole food plant-based diet and lifestyle have been shown to reverse plaque, but there's a threshold to this and it's not for everybody. So I tell people, if you have a calcium score of 1,000, right, it's not a very realistic goal to expect a complete reversal of plaque. But we can definitely stabilize the existing plaque. We can prevent it from causing you any problems. Just you're not going to go from a calcium score of 1,000 to nothing, and that would not be common. So yeah, in that way, yes, it's possible, but it's not also common after a certain threshold.
Is calcium intermediate thickness, CIMT, a good test to detect early stage?
CIMT stands for carotid intermediate thickness, and that's an ultrasound of the neck, a carotid artery based parameter. It's not a great test because the studies that looked at it did not show an increased risk discrimination. Remember, I said I want to take a bunch of people and I want to split them into high risk or low risk. It doesn't do that great a job, especially once you adjust for things like a calcium score. So a calcium score is a better test. If you see plaque in the carotid, not just thickening of the carotid, but you see actual plaque in the carotid, that could move the needle a little bit. But again, nothing is as good of a risk predictor as calcium scores are.
Is there a way to address high lipoprotein A? Do lifestyle changes help? And subsequent was the recommendation of statins or PSK9 inhibitors.
Sure. Reducing of lifestyle. Yes. Okay. So lipoprotein A, like we said, it's genetically inherited. So you probably got it from your parents if you have it. Lifestyle doesn't do too much for it. It's almost fairly constant throughout your life. Postmenopausal women, we sometimes see rises in lipoprotein A. So if you're perimenopausal and your levels were sort of borderline, it may be worth checking it in postmenopause to see if it went up. It is associated, we think almost causally, meaning we think it causes premature heart disease just based on the studies that exist. But till today, we have never proven the opposite. So we have never proven that reducing your lipoprotein A actually helps reverse heart disease or prevents heart disease progression. So as of today, we don't really know if anything we do in terms of medicines to reduce lipoprotein A, and we have medicines, but we don't know if that means anything. So we'll have to wait on data to find out if it actually means anything, and we think it will, but we don't know for sure. I'll give you an example. Vitamin D is one of those markers. If you have a low vitamin D, that is associated with all kinds of things. So heart disease, bone disease, all kinds of things. But it turns out when we actually supplement vitamin D and give people vitamin D, the number of things it improves is not that many. So it doesn't, for example, it doesn't improve your risk for heart disease if you have low vitamin D and I give you vitamin D. So there are a lot of things which are association, but not really causal. Lipoprotein A, I don't think is going to go down that route, but if we haven't proven it yet. So no, lifestyle changes don't do too much to help your lipoprotein A. Statins are recommended in the sense that we have one risk factor that we cannot touch, so we're trying to reduce every other risk factor that we can. And in that sense, yes, it lowers your LDL, so immediately lowers your LDL mediated risk, but it doesn't do anything to your lipoprotein A mediated risk. The question about PCSK9 inhibitor is interesting. For people who don't know, PCSK9 inhibitor is an injectable cholesterol lowering medication. You might have seen ads on TV, like there you get brand names, Repatha, Praluent. And what they do is they lower your LDL. So it's kind of like it's like a statin, but it works a little bit differently, it works a little better even sometimes. PCSK9 inhibitors do lower your lipoprotein A. So you get a 25 to 30% lowering of your lipoprotein A with PCSK9 inhibitors. Again, we don't know if that means anything. We think it could, but we don't know if that means anything for your outcomes or your risk for heart attack. And we also don't know if that's enough. There are other drugs that reduce LPA by 25 to 30%, but they don't affect cardiovascular risk. So we don't know if the benefit you're getting from the PCSK9 inhibitor, the evolocumab, is really driven by the LPA lowering or not. All of this is a really long way to say that it's not unreasonable in some people to try a PCSK9 inhibitor, especially if you also want to lower LDL. But at least today, I don't prescribe it. If you have no heart disease and you have no other reason for a PCSK9 inhibitor, I don't reach for it before the statin.
And what's the ideal body weight? There's a question on that.
You want to focus on waist circumference if you can. So the 90 and 80 that I said, those are good cutoffs. And then, the things you can do, I didn't go into this, but the things you can do to improve your visceral obesity are really exercise, strength training, cutting carbohydrates, especially simple carbohydrates can be very helpful. And you want to do more complex carbohydrates, more fibers, more fiber, that kind of thing.
So there's a question on soluble fiber foods.
Yeah.
Can reduce the LDL by 5 to 10%.
It can, absolutely. It can. Now, a lot of LDL is genetically mediated, so it's not going to work for everybody. But I still tell people, really up your fiber intake. When you do that, you're automatically eating healthy also. So you're eating more fruits, you're eating more vegetables, more greens, more say like chia seeds, that kind of thing. It can lower LDL. And in some people very dramatically. And a part of that depends on the balance between how much of your cholesterol is made by the liver versus how much of it is absorbed from your diet. So yes, that is true. It can help. And I tell everybody it's worth trying.
Is taking blood pressure better in the morning or evening?
It depends. So we recommend taking it, if you're looking to diagnose hypertension, we'll actually ask you to take it twice a day, like once in the morning, once in the night. The biggest things to remember are the technique matters. If you don't do it with the correct technique, and you could Google this, there are lots of infographics by AMA and other organizations on how to check your blood pressure. But if you don't do it in the correct way, it can both over and underestimate your blood pressure. So you may be getting readings, but they may not be good readings. So the most important thing, it doesn't matter about time, but you wanna really check it in the correct way. You can't do it on a full bladder, not right after coffee, not right after exercise. So there are a lot of restrictions around how you should check your blood pressure, but it's extremely important that you do that when you do it at home.
Is CAC test useful for some 75 years and above with no symptoms?
Typically not recommended, but it depends. There are limitations on what the guidelines recommend because that's where the data is. Our data kind of ends with 75-year-olds in the big studies, and that's why we don't do too much of CAC testing beyond that. But LDL lowering above 75 could be beneficial. There are trials ongoing, so we don't have the full data yet, but there's some suggestions that, healthy, like 75-year-olds could benefit from lowering your LDL. And if a calcium score can be used as a decision aid, then in certain situations, maybe. But no, I wouldn't do it routinely, though.
Okay. And why are diabetics more susceptible to heart attacks? And what should their LDL level be?
Good question. So when someone has diabetes, what happens is you get injury to the arterial wall, and there are changes in the cell itself when you have diabetes, and there are these products we call advanced glycosylation end products that basically injure the arterial wall. And as the anything that injures the arterial wall will increase the chance of plaque formation. So that's why they're more susceptible to heart attacks, and that's why prevention becomes super important in them. Lifestyle is a huge piece of this too. Like you can make a serious difference in this risk with lifestyle. And that's why their LDL should be as low as 75, because we want to try and take away, when you have one risk factor, we want to try and take away every other risk factor that can contribute to heart attacks, right? So if you have diabetes, that's one risk factor you already have. We want to try and take away the LDL. We want to control your blood pressure. We want to ask you to exercise. So we're doing all of these things to take away additional insults to the vessel wall.
Then the question is, what causes plaque? Diet, sleep, or stress?
Sort of all of an above. Some of it is genetically mediated, like your cholesterol levels are very genetically mediated. Lifestyle plays a role, but not always. And having a high LDL is thought to be one of the central tenets of what causes atherosclerosis. In fact, there have been studies looking at people whose LDLs are 30 throughout their lifetime, and they don't have a lot of plaque. So there's definitely a big thought among some people that if we keep everybody's LDL like in the 30s from their young age, maybe we will not have any atherosclerosis. I don't know that there's data to support that for sure, but there's no trials per se that do that from a young age. So it's a risk benefit, because to get to 30, you need medications many times. And if we get everybody to 30, maybe we will not see plaque deposition at all. But the other things that injure the wall also matter. So diabetes, hypertension, stress plays a role. Lack of sleep has been associated with it. The diet definitely plays a role. So it's not one thing. It's a lot of things. And when you attack it and you try to address it from a prevention standpoint, also, you want to address all of these things, not just one thing.
And what are your thoughts on plant stenols or sterols, and how often do you use this in your practice?
I don't, because, okay, two things. One is the most effective ways to lower the LDL level are really not any of these supplements. They may work in some people. The second thing is there are some people who really overabsorb these sterols, and you can end up with problems if you are one of those people. So I don't recommend it. I'd rather you take something that has been studied. We know exactly what the side effects are. We know exactly what to watch for. So I'd rather you take something that's a little more regulated as well, compared to the supplements, which it's a whole other conversation, but the regulation around supplement use leaves a lot to be desired.
And can psyllium husk be used to lower cholesterol?
Sorry, what was that?
Psyllium husk.
Psyllium husk, yeah, it's fiber. So just like fiber, whether you get it through your diet and supplementation, I'd recommend trying diet first. But taking a little extra psyllium husk, don't do it very quickly. Your GI tract will not like it. But typically, I say try diet first.
Okay. And how much of LDL risk is mitigated by increasing your HDL?
Oh, great question. It's not a lot. So a high HDL is in population studies, a good thing, but on an individual level, it's almost a U-shaped curve. So there's a sweet Goldilocks zone where you could have a slightly lower risk, but it doesn't really take away the LDL mediated risk. So a lot of people will tell me, oh, my LDL to HDL ratio is normal, so I'm protected. That's not entirely true. That's great for population studies, but not great for individual risk. If you want to lower your individual risk, lower your LDL, lower your ApoB. That's the better way to go.
Okay. And what are the screening methods for fatty liver?
So you can get a clue with your blood work. So if your liver enzymes are elevated, you can get a clue, but you don't, you can have normal liver enzymes and still have fatty liver. So the real way to look for fatty liver is ultrasound. There are other tests like your CT scans can give you some clue. There are MRIs that can give you a little bit more at like accurate estimation of fat. But an ultrasound is a fairly commonly used tool to screen for fatty liver.
Your thoughts on ketogenic diet, specifically grass-fed beef.
Okay. This gets into a lot of the which diet do you follow. The data on ketogenic diet seems to suggest that in a majority of people, it increases plaque progression. So on average, animal heavy ketogenic diet does increase plaque progression. Are there some people who have no plaque at all in whom a ketogenic diet does not do this? That is tricky, and there are some people who believe that that may be true. But for a majority of people, don't typically recommend a very saturated fat heavy ketogenic diet. Now, the keto diet itself, you can do like a Mediterranean keto. Like that, you're eating like healthy foods that are just not high in carbohydrates. That can be an effective weight loss strategy. But if you're eating a lot of saturated fat, grass-fed or otherwise, that has reliably been associated with both heart disease risk and rise in LDL levels. So my patients who do that and they find that that's an effective technique, I'll tell them, we need to at least monitor your LDL and monitor your inflammation because that's the other thing that goes up. So though with those two caveats, if you really want to consider it, that may be considerable, but typically I don't recommend it. There are so many other diets that have much better proven health benefits that I typically don't recommend that as the first line attempt.
Okay. Does CoQ10 help?
It can help some people. So I don't recommend it I don't recommend it for everybody. In some people who have statin-associated muscle symptoms, meaning pain that comes on when you take a statin, goes away when you don't take a statin, taking CoQ10, there are some people it benefits. In the large trials, it did not help. When we studied it, it did not really help. But am I opposed to you trying that if it'll help you stay on your statin and it's helping you? Probably not.
Then how to increase the HDL levels? Say if you have 37 and you're a male and you want to be above 40.
Get your metabolic syndrome under control. So all of the lifestyle things that we talked about, as your metabolic syndrome gets better, HDL can come up. Not all HDL is driven by metabolic syndrome though. So, you don't want to shoot for the number. You want to shoot for the underlying problem. So I haven't even mentioned HDL in my talk today because it's HDL number does not correlate with HDL function, and there's a lot of nuance to it. So in the big picture is I would not try to just raise your HDL for the sake of raising HDL. I would do it because treating metabolic syndrome is good for you and it also raises HDL.
And so if your A1C is now under 6 but was 8 earlier, are you still diagnosed with diabetes?
There is a concept of remission from diabetes. So I believe it's A1C under 6 and it's greater than a year. If you've sustained it off of medications greater than a year, I think we call it remission. Now, the underlying insulin resistance, if you measure insulin resistance, and there's ways to do that, sometimes we still see residual insulin resistance. So the lifestyle and everything still matters. You want to try and maintain whatever got you into the remission, but yes, it exists.
Okay. And then the question is how to enroll in masala study. Probably go to the website, right?
Go to the website. It would be, my best guess. I'm not a masala investigator, but I'm sure if you go to the website, there's a way to do it.
Okay, there's some personal questions like before noontime blood pressure is low, 68/44, and by afternoon it starts going up to 129/54. What could be wrong?
I think that's a very personalized question. You kind of have to work with your doctor on that, check the technique, check like timing of medication. So there's a lot of things that could be doing that. Like what is your hydration in the morning, what you eating. So there are a lot of things that could be doing that. So but 68 over 44 is low. So definitely let your doctor know.
Yeah. Think some of them are personal questions. Probably I'll just skip those.
There was one that says, what does it mean if LDL particle count is high and LDL small is high? How does this associate with ApoB? And that's a good question. So if you have a lot of small particles, your count is going to be high. That's what that means. So if you have small particles and you have a lot of them, remember the picture where I showed you particles versus 10 small particles? When you're getting a particle count, you're essentially just counting those particles. And an ApoB is a measure. It's just a different way to get at the same thing. So different way to get at the particle count.
The question on fish oil for patients with normal triglycerides, low HDL, elevated LDL, pre-diabetes, would you recommend?
Not typically recommended. The effect on LDL is there is an effect, but it's nowhere as powerful as the other ApoB lowering medications. The fish oil that we use for cardiovascular risk reduction is high dose purified EPA. And it's called Vasipa. And it was only studied in people with triglycerides. And so we don't typically recommend it with like a normal triglyceride. I also don't recommend it as a prevention med.
How to increase your vitamin D? What supplements would you recommend?
Typically almost none. There are concerns about how these supplements are regulated, and if you do one, you want to get one that's like NSF verified. But treat to deficiency is all I would do. There was a question on side effects of statin. I think this is worth mentioning because this comes up a lot. Statins have been around forever, since 1980s, I think, if I'm not wrong. And so we know a lot about lots of people are on them. We know exactly what they do. We know exactly what their side effects are, what their long-term effects are, much more than we do for many other medications. The biggest side effects with statins are muscle pain. So you're not damaging muscle, you're not breaking muscle, but you can have pain. In fact, 10 to 30% of people who are on a high intensity statin, which is a very specific dose of high dose, they can have some muscle related symptoms. Not as common in lower doses. So many times what I will do in people who haven't had a heart attack, I will do a low dose statin, and that's still very effective, but you don't get the muscle related side effects. The other thing to know is if you have muscle related side effects on one statin, sometimes trying another statin can work. Sometimes changing the dose can work. So it's not that if you've like had pain with one statin, you're never going to take a statin again. Statin muscle injury, what we call myositis, where you're actually damaging muscle, is super rare. It's like so rare that we'd publish it as a case report if it happens. So that is the biggest thing that you'll hear about a lot. It can worsen glycemic control by a very small amount. So insulin resistance can get a little bit worse on high intensity statins. Again, not that common on lower intensity statins. Those are the two big ones. Everything else that's on the internet, unfortunately, is a lot of hype. So it doesn't cause dementia. There have been large studies looking at statins and dementia, and if anything, it may protect against some forms of dementia. Definitely vascular dementia, it seems to protect against. It doesn't cause cancer. It doesn't cause liver injury. In fact, we typically don't even recommend like immediately checking your liver enzymes right after you start a statin. It's just routine checks that you get for it. So liver injury is also not at all common. It doesn't cause kidney injury. None of that. None of that really happens with the statins. Actually, one of the safest meds I prescribe, also the one I get the most pushback on.
And is there any other medications without statins for cholesterol?
There are plenty of options. So just because, you tried, say, 3 statins and all of them gave you muscle pains doesn't mean you're doomed. So the PCSK9 inhibitors that somebody asked about, that one's fairly commonly used. That reduces your LDL. There's ezetimibe, which helps reduce your LDL. There's this compound called bempedoic acid, which is a long name, but that also works. And these are all non-statins, by the way. So if you're having muscle pains with a statin, these are options. There's also inclisiran, which is every 6 months. So there are other options for if you decide to go down the med route and for some reason you can't tolerate a statin, I'd still recommend trying if you can take every other day, take a lower dose, try CoQ10. If any of those help you be on it, then you're on a med that has so much safety data for so many years.
Okay, one more last question on statins.
Okay.
Does your body get used to it? Like it's immune, like over the years, in 5 to 10 years, does the dose increase?
Not really. Not really. As you grow older, your parameters tend to get worse. So your metabolic parameters do tend to get worse, especially women post-menopause. We see sort of a flip sometimes. So you could develop it just because you're developing metabolic syndrome. Your numbers could get worse, but not because you're developing, autoimmunity to statin. Very, very rare to have autoimmune statin-induced myositis, muscle injury. Very, very rare.
And I think we can do one last question probably. Is HRT a way to help with lipids?
Not recommended just to lower your cholesterol, but that's a very nuanced topic. So you should definitely talk to your doctor. There's newer data that HRT is not, as risky as we once thought it would be from a cardiovascular standpoint, strictly from a cardiovascular standpoint. There are other things you need to consider, like breast cancer risk and cancer risk and stuff, but may be safe if you need it for symptoms, but don't recommend it just for your cholesterol.
Okay. Can we do one more question, Ashish?
Yeah, and once
Okay.
you do your question, I have one question for Dr. Satish as well.
Sure.
Okay. Thoughts on intermittent fasting and cardiac health?
Effective. Any method that reduces your total caloric intake can help with weight loss. So, we talked about the keto diet, right? One of the reasons it's so effective is because you're dropping your total calories. So if you compare a low calorie keto diet with a low calorie some other diet, like low fat diet, for example, the weight loss ends up being fairly similar. So it's the calorie restriction that's really helping you. Intermittent fasting is a good way to do it. There's a lot of data around it. You just have to be careful about maintaining your protein intake when you do it, and then not overeating when you start eating, because that can happen. You don't want to catch up calories just because you were fasting and now you're starving. So that's the thing you need to be careful about.
Right, Ashish.
Yeah. So thank you so much, Dr. Satish, for this wonderful presentation. Actually, you went into it in a fair amount of depth, which I really, really liked. I think there's so many myths around the calcium scoring that you helped resolve as well. And a lot of questions that I saw forthcoming were around the use of statins to reduce LDL. One question that I had for that is your experience with the use of statins in the advent of prediabetes and diabetes. Can you talk about that a little bit?
There's definitely a small increased risk. The risk is especially seen in people with prediabetes. So there's a small increased risk of conversion from prediabetes to diabetes. So the way I deal with this in my practice is, if I do end up starting a statin because say you have coronary calcium, right? You have plaque and it'll benefit you. Then we keep an eye out on your A1C and we really dial down on the lifestyle things, because prediabetes, 1/3 of that just doesn't progress at all. And if you follow a good lifestyle, you can reverse a lot of that. So the lifestyle part of this becomes super important. And we, every single person that I start this med on, I will still let them know that this is important. Now, this is not to scare people, because if people have diabetes, we still recommend a statin, because even if you have diabetes, you're still getting a benefit from a cardiovascular standpoint from a statin. So it's not that if you have prediabetes, you should not be on a statin. But I typically try to do lower doses where your progression to diabetes, that risk ends up being a little bit lower. And then really dial down on the lifestyle factors that can help reverse it.
All right. Well, thank you so much for today. I think we had a packed schedule, and look at the amount of questions that everybody had. So there's clearly need for more presentations like this in terms of educating the issue. I think Dr. Satish, you had also mentioned the Brown Heart documentary. I think it's a must-see for everybody. It's a very, very comprehensive coverage. Dr. Satish actually has been featured in the Brown Heart, and so has the South Asian Heart Center. So we are out there to, help the community navigate these epidemics. And I really appreciate the time that you've spent with educating the community here.
Of course, and if people are interested, the Brown Heart folks have actually started a WhatsApp group where they open it up for questions and they do a deep dive into every single question, and they're doing it purely out of a volunteer basis. So I think it's a great group if anybody's interested. And I believe you can join it through their website.
Right, and it's and then they also are posting a lot of blogs and reels and others on many topics that remove these myths as well. So very, very good resource within the community.